Clinical testing of drugs. Experiments conducted on animals are essential to the development of new chemicals for the management of disease. The safety and efficacy of new drugs, however, can be established only by adequate and well-controlled studies on human subjects. Since findings in animals do not always accurately predict the human response to drugs, subjects who participate in clinical trials are put at some degree of risk. The risk comes not only from the potential toxicity of the new drug but also from possible lack of efficacy, with the result that the condition under treatment becomes worse. Since risk is involved, the primary consideration in any clinical trial should be the welfare of the subject. As a consequence of unethical or questionably ethical practices committed in the past, most countries have established safeguards to protect the rights and welfare of persons who participate in clinical trials. Two of the safeguards that have been established are the Institutional Review Board, IRB, and the requirement for informed consent. The IRB, also known as the Ethics Committee or Human Subjects Committee, originally was established to protect people confined to hospitals, mental institutions, nursing homes, and prisons who may be used as subjects in clinical research. In the United States, any institution conducting clinical studies supported by federal funds is required to have proposed studies reviewed and approved by an IRB. People who volunteer to be subjects in a drug study have a right to know what can and will happen to them if they participate. Informed consent. The investigator is responsible for ensuring that each subject receives a full explanation, in easily understood terms, of the purpose of the study, the procedures to be employed, the nature of the substances being tested, and the potential risks, benefits, and discomforts. Phases of clinical investigation. The clinical development of new drugs usually takes place in steps or phases conventionally described as Phase I clinical pharmacology, Phase II clinical investigation, Phase III clinical trials, Phase IV post-marketing studies. Table 1.1 summarizes the four phases of clinical evaluation. Phase I. When a drug is administered to humans for the first time, the studies generally have been conducted in healthy men between 18 and 45 years of age. This practice is coming under increasing scrutiny and criticism. For certain types of drugs, such as antineoplastic agents, it is not appropriate to use healthy subjects because the risk of injury is too high. The purpose of Phase I studies is to establish the dose level at which signs of toxicity first appear. The initial studies consist of administering a single dose of the test drug and closely observing the subject in a hospital or clinical pharmacology unit with emergency facilities. If no adverse reactions occur, the dose is increased progressively until a predetermined dose or serum level is reached or toxicity supervenes. Phase I studies are usually confined to a group of 20 to 80 subjects. If no untoward effects result from single doses, short-term multiple-dose studies are initiated. Phase II. If the results of Phase I studies show that it is reasonably safe to continue, the new drug is administered to patients for the first time. Ideally, these individuals should have no medical problems other than the condition for which the new drug is intended. Efforts are concentrated on evaluating efficacy and on establishing an optimal dose range. Therefore, dose-response studies are a critical part of Phase II studies. Monitoring subjects for adverse effects is also an integral part of Phase II trials. The number of subjects in Phase II studies is usually between 80 and 100. Phase IV. When an effective dose range has been established and no serious adverse reactions have occurred, large numbers of subjects can be exposed to the drug. In Phase III studies, the number of subjects may range from several hundred to several thousand, depending on the drug. The purpose of Phase III studies is to verify the efficacy of the drug and to detect effects that may not have surfaced in the Phase I and II trials, during which exposure to the drug was limited. A new drug application is submitted at the end of Phase III. However, for drugs intended to treat patients with life-threatening or severely debilitating illnesses, especially when no satisfactory therapy exists, the FDA has established procedures designed to expedite development, evaluation, and marketing of new therapies. In the majority of cases, the procedure applies to drugs being developed for the treatment of cancer and acquired immunodeficiency syndrome, AIDS. Under this procedure, drugs can be approved on the basis of Phase 2 studies conducted in a limited number of patients. Phase V, controlled and uncontrolled studies often are conducted after a drug is approved and marketed. Such studies are intended to broaden the experience with the drug and compare it with other drugs. Special populations. One of the goals of drug development is to provide sufficient data to permit the safe and effective use of the drug. Therefore, the patient population that participates in clinical trials should be representative of the patient population that will receive the drug when it is marketed. To a varying extent, however, women, children, and patients over 65 years of age have been underrepresented in clinical trials of new drugs. The reasons for exclusion vary, but the consequence is that prescribing information for these patient populations is often deficient. Adverse reaction surveillance. Almost all drugs have adverse effects associated with their use. These range in severity from mild inconveniences to severe morbidity and death. Mechanisms of drug action. Receptors. A fundamental concept of pharmacology is that to initiate an effect in a cell, most drugs combine with some molecular structure on the surface of or within the cell. This molecular structure is called a receptor. The combination of the drug and the receptor results in a molecular change in the receptor, such as an altered configuration or charge distribution, and thereby triggers a chain of events leading to a response. This concept applies not only to the action of drugs but also to the action of naturally occurring substances, such as hormones and neurotransmitters. Indeed, many drugs mimic the effects of hormones or transmitters because they combine with the same receptors as do these endogenous substances. It is generally assumed that all receptors with which drugs combine are receptors for neurotransmitters, hormones, or other physiological substances. Thus, the discovery of a specific receptor for a group of drugs can lead to a search for previously unknown endogenous substances that combine with those same receptors. For example, evidence was found for the existence of endogenous peptides with morphine-like activity. A series of these peptides have since been identified and are collectively termed endorphins and enkephalins. It is now clear that drugs such as morphine merely mimic endorphins or enkephalins by combining with the same receptors. Drug receptors and biological responses. Although the term receptor is convenient, one should never lose sight of the fact that receptors are in actuality molecular substances or macromolecules in tissues that combine chemically with the drug. Since most drugs have a considerable degree of selectivity in their actions, it follows that the receptors with which they interact must be equally unique. Thus, receptors will interact with only a limited number of structurally related or complementary compounds. The drug-receptor interaction can be better appreciated through a specific example. The end plate region of a skeletal muscle fiber contains large numbers of receptors having a high affinity for the transmitter acetylcholine. Each of these receptors, known as nicotinic receptors, is an integral part of a channel in the postsynaptic membrane that controls the inward movement of sodium ions. At rest, the postsynaptic membrane is relatively impermeable to sodium. Stimulation of the nerve leading to the muscle results in the release of acetylcholine from the nerve fiber in the region of the end plate. The acetylcholine combines with the receptors and changes them so that channels are opened and sodium flows inward. The more acetylcholine the end plate region contains, the more receptors are occupied and the more channels are open. When the number of open channels reaches a critical value, sodium enters rapidly enough to disturb the ionic balance of the membrane, resulting in local depolarization. The local depolarization, end plate potential, triggers the activation of large numbers of voltage-dependent sodium channels, causing the conducted depolarization known as an action potential. The action potential leads to the release of calcium from intracellular binding sites. The calcium then interacts with the contractile proteins, resulting in shortening of the muscle cell. The sequence of events can be shown diagrammatically as follows: ACH end receptor RNA influx action potential. are increased free CAR contraction, where ACH equals acetylcholine. The precise chain of events following drug-receptor interaction depends on the particular receptor and the particular type of cell. The important concept at this stage of the discussion is that specific receptive substances serve as triggers of cellular reactions. If we consider the sequence of events by which acetylcholine brings about muscle contraction through receptors, we can easily appreciate that foreign chemicals, drugs, can be designed to interact with the same process. Thus, such a drug would mimic the actions of acetylcholine at the motor end plate. Nicotine and carbamylcholine are two drugs that have such an effect. Chemicals that interact with a receptor and thereby initiate a cellular reaction are termed agonists. Thus, acetylcholine itself, as well as the drugs nicotine and carbamylcholine, are agonists for the receptors in the skeletal muscle end plate. On the other hand, if a chemical is somewhat less similar to acetylcholine, it may interact with the receptor but be unable to induce the exact molecular change necessary to allow the inward movement of sodium. In this instance, the chemical does not cause contraction, but because it occupies the receptor site, it prevents the interaction of acetylcholine with its receptor. Such a drug is termed an antagonist. An example of such a compound is tubocurarine, an antagonist of acetylcholine at the end plate receptors. Since it competes with acetylcholine for its receptor and prevents acetylcholine from producing its characteristic effects, administration of tubocurarine results in muscle relaxation by interfering with acetylcholine's ability to induce and maintain the contractile state of the muscle cells. Historically, receptors have been identified through recognition of the relative selectivity by which certain exogenously administered drugs, neurotransmitters, or hormones exert their pharmacological effects. By applying mathematical principles to dose-response relationships, it became possible to estimate dissociation constants for the interaction between specific receptors and individual agonists or antagonists. Subsequently, methods were developed to measure the specific binding of radioactively labeled drugs to receptor sites in tissues and thereby determine not only the affinity of a drug for its receptor, but also the density of receptors per cell. In recent years, much has been learned about the chemical structure of certain receptors. The nicotinic receptor on skeletal muscle, for example, is known to be composed of 5 subunits, each a glycoprotein weighing 40,000 to 65,000 Daltons. These subunits are arranged as interacting helices that penetrate the cell membrane completely and surround a central pit that is a sodium ion channel. The binding sites for acetylcholine and other agonists that mimic it are on one of the subunits that project extracellularly from the cell membrane. The binding of an agonist to these sites changes the conformation of the glycoprotein so that the side chains move away from the center of the channel, allowing sodium ions to enter the cell through the channel. The glycoproteins that make up the nicotinic receptor for acetylcholine serve as both the walls and the gate of the ion channel. This arrangement represents one of the simpler mechanisms by which a receptor may be coupled to a biological response. Second messenger systems. Many receptors are capable of initiating a chain of events involving second messengers. Key factors in many of these second messenger systems are proteins termed G proteins, short for guanine nucleotide binding proteins. G proteins have the capacity to bind guanosine triphosphate, GTP, and hydrolyze it to guanosine diphosphate, GDP. G proteins couple the activation of several different receptors to the next step in a chain of events. In a number of instances, the next step involves the enzyme Adenylyl Cyclase. Many neurotransmitters, hormones, and drugs can either stimulate or inhibit Adenylyl Cyclase through their interaction with different receptors. These receptors are coupled to Adenylyl Cyclase through either a stimulatory, GAD or an inhibitory, GO, G protein. During the coupling process, the binding and subsequent hydrolysis of GTP to GDP provides the energy needed to terminate the coupling process. The activation of Adenylyl Cyclase enables it to catalyze the conversion of adenosine triphosphate, ATP, to 3,5-cyclic adenosine monophosphate, CAMP, which in turn can activate a number of enzymes known as kinases. Each kinase phosphorylates a specific protein or proteins. Such phosphorylation reactions are known to be involved in the opening of some calcium channels as well as in the activation of other enzymes. In this system, the receptor is in the membrane with its binding site on the outer surface. The G protein is totally within the membrane while the adenylyl cyclase is within the membrane but projects into the interior of the cell. The CAMP is generated within the cell. Whether or not a particular agonist has any effect on a particular cell depends initially on the presence or absence of the appropriate receptor. However, the nature of the response depends on these factors, which G protein couples with the receptor, which kinase is activated, which proteins are accessible for the kinase to phosphorylate. The variety of possible responses is further increased by the fact that receptor-coupled G proteins can either activate enzymes other than adenylate cyclase or can directly influence ion channel functions. Many different receptor types are coupled to G proteins, including receptors for norepinephrine and epinephrine, alpha and beta adrenoceptors, 5-hydroxytryptamine, serotonin or 5-HT receptors, and muscarinic acetylcholine receptors. All members of this family of G protein-coupled receptors are characterized by having 7 membrane-enclosed domains plus extracellular and intracellular loops. The specific binding sites for agonists occur at the extracellular surface, while the interaction with G proteins occurs with the intracellular portions of the receptor. The general term for any chain of events initiated by receptor activation is signal transduction. The chemistry of drug receptor binding. Biological receptors are capable of combining with drugs in a number of ways, and the forces that attract the drug to its receptor must be sufficiently strong and long-lasting to permit the initiation of the sequence of events that ends with the biological response. Those forces are chemical bonds, and a number of types of bonds participate in the formation of the initial drug-receptor complex. The bond formed when 2 atoms share a pair of electrons is called a covalent bond. It possesses a bond energy of approximately 100 kcal/mol and therefore is strong and stable, that is, it is essentially irreversible at body temperature. Covalent bonds are responsible for the stability of most organic molecules and can be broken only if sufficient energy is added or if a catalytic agent that can facilitate bond disruption, such as an enzyme, is present. Since bonds of this type are so stable at physiological temperatures, the binding of a drug to a receptor through covalent bond formation would result in the formation of a long-lasting complex. Although most drug-receptor interactions are readily reversible, some compounds, such as the anti-cancer nitrogen mustards, see Chapter 56, and other alkylating agents form relatively irreversible complexes. Covalent bond formation is a desirable feature of an antineoplastic or antibiotic drug, since long-lasting inhibition of cell replication is needed. However, covalent bond formation between environmental pollutants and cellular constituents may result in mutagenesis or carcinogenesis in normal, healthy cells. The formation of an ionic bond results from the electrostatic attraction that occurs between oppositely charged ions. The strength of this bond is considerably less, 5 kcal/mol, than that of the covalent bond and diminishes in proportion to the square of the distance between the ionic species. Most macromolecular receptors have a number of ionizable groups at physiological pH, example carboxyl, hydroxyl, phosphoryl, amino, that are available for interaction with an ionizable drug. The hydrogen atom, with its strongly electropositive nucleus and single electron, can be bound to one strongly electronegative atom and still accept an electron from another electronegative donor atom, such as nitrogen or oxygen, and thereby form a bridge, hydrogen bond, between these 2 donor atoms. The formation of several such bonds between 2 molecules, example drug and receptor, can result in a relatively stable but reversible interaction. Such bonds serve to maintain the tertiary structure of proteins and nucleic acids and are thought to play a significant role in establishing the selectivity and specificity of drug and become biologically important only when 2 atoms are brought into sufficiently close contact. Van der Waals forces play a significant part in determining drug receptor specificity. Like the hydrogen bonds, several van der Waals bonds may be established between 2 molecules, especially if the drug molecule and a receptor have complementary three-dimensional conformations and thus fit closely together. The closer the drug comes to the receptor, the stronger the possible binding forces that can be established. Slight differences in three-dimensional shape among a group of agonists and therefore slight differences in fit or strength of bonding forces that can be established between agonists and receptor form the basis for the structure-activity relationships among related agonists. Dynamics of drug-receptor binding. The drug molecule, following its administration and passage to the area immediately adjacent to the receptor surface, sometimes called the biophase, must bond with the receptor before it can initiate a response. Resisting this bond formation is a random thermal agitation that is inherent in every molecule and tends to keep the molecule in constant motion. Under normal circumstances, the electrostatic attraction of the ionic bond, which can be exerted over longer distances than can the attraction of either the hydrogen or van der Waals bond, is the first force that draws the ionized molecule toward the oppositely charged receptor surface. This is a reasonably strong bond and will lend some stability to the drug-receptor complex. Generally, the ionic bond must be reinforced by a hydrogen or van der Waals bond or both before significant receptor activation can occur. This is true because unreinforced bonds are too easily and quickly broken by the energy of thermal agitation to permit sufficient time for adequate drug-receptor interaction to take place. The better the structural congruity, i.e., fit, between drug and its receptor, the more secondary, i.e., hydrogen and van der Waals, bonds can form. Even if extensive binding has taken place, unless covalent bond formation has occurred, the drug-receptor complex can still dissociate. Once dissociation has occurred, drug action is terminated. For most drug-receptor interactions, there is a continual random association and dissociation. The frequencies of association and dissociation are a function of the affinity between the drug and the receptor, the density of receptors, and the concentration of drug in the biophase. The magnitude OF the response is general Y considered to be a function OF the concentration OF the drug-receptor complexes formed at any moment in time. Dose-response relationship. To understand drug-receptor interactions, it is necessary to quantify the relationship between the drug and the biological effect it produces. Since the degree of effect produced by a drug is generally a function of the amount administered, we can express this relationship in terms of a dose-response curve. Because we cannot always quantify the concentration of drug in the biophase in the intact individual, it is customary to correlate effect with dose administered. In general, biological responses to drugs are graded, that is, the response continuously increases, up to the maximal responding capacity of the given responding system, as the administered dose continuously increases. Expressed in receptor theory terminology, this means that when a graded dose-response relationship exists, the response to the drug is directly related to the number of receptors with which the drug effectively interact. This is one of the tenets of pharmacology. The principles derived from dose-response curves are the same in animals and humans. However, obtaining the data for complete dose-response curves in humans is generally difficult or dangerous. We shall therefore use animal data to illustrate these principles. Quantal relationships. In addition to the responsiveness of a given patient, one may be interested in the relationship between dose and some specified quantum of response among all individuals taking that drug. Such information is obtained by evaluating data obtained from a quantal dose-response curve. Anticonvulsants can be suitably studied by use of quantal dose-response curves. For example, to assess the potential of new anticonvulsants to control epileptic seizures in humans, these drugs are initially tested for their ability to protect animals against experimentally induced seizures. In the presence of a given dose of the drug, the animal either has the seizure or does not, that is, it either is or is not protected. Thus, in the design of this experiment, the effect of the drug, protection, is all or none. This type of response, in contrast to a graded response, must be described in a non-continuous manner. The construction of a quantal dose-response curve requires that data be obtained from many individuals. Although any given patient, or animal, either will or will not respond to a given dose, a comparison of individuals within a population shows that members of that population are not identical in their ability to respond to a particular dose. This variability can be expressed as a type of dose-response curve, sometimes termed a quantal dose-response curve, in which the dose, plotted on the horizontal axis, is evaluated against the percentage of animals in the experimental population that is protected by each dose, vertical axis. Such a dose-response curve for the anticonvulsant phenobarbital is illustrated in Figure 2.2a. 5 groups of 10 rats per group were used. The animals in any one group received a particular dose of phenobarbital of 2, 3, 5, 7, or 10 mg per kilogram body weight. The percentage of animals in each group protected against convulsions was plotted against the dose of phenobarbital. As Figure 2.2a shows, the lowest dose protected none of the 10 rats to which it was given, whereas 10 mg per kilogram protected 10 of 10. With the intermediate doses, some rats were protected and some were not. This indicates that the rats differ in their sensitivity to phenobarbital. The quantal dose-response curve is actually a cumulative plot of the normal frequency distribution curve. The frequency distribution curve, in this case relating the minimum protective dose to the frequency with which it occurs in the population, generally is bell-shaped. If one graphs the cumulative frequency versus dose, one obtains the sigmoid-shaped curve of Figure 2a. The sigmoid shape is a characteristic of most dose-response curves when the dose is plotted on a geometric, or log, scale. Therapeutic Index elective dose. The quantal dose-response curve represents estimates of the frequency with which each dose elicits the desired response in the population. In addition to this information, it also would be useful to have some way to express the average sensitivity of the entire population to phenobarbital. This is done through the calculation of an ED, effective dose, 50%, i.e., the dose that would protect 50% of the animals. This value can be obtained from the dose-response curve in Figure 2a, as shown by the broken lines. The ED for phenobarbital in this population is approximately 4 mg per kilogram. Lethal dose. Another important characteristic of a drug's activity is its toxic effect. Obviously, the ultimate toxic effect is death. A curve similar to that already discussed can be constructed by plotting percent of animals killed by phenobarbital against dose, Fig 2b. From this curve, one can calculate the LD, lethal dose, 50%. Since the degree of safety associated with drug administration depends on an adequate separation between doses producing a therapeutic effect, example ED, and doses producing toxic effects, example LD, one can use a comparison of these two doses to estimate drug safety. Thus, one estimate of a drug's margin of safety is the ratio LD/ED. This is the therapeutic index. The therapeutic index for phenobarbital used as an anticonvulsant is approximately 40/4, or 10. As a general rule, a drug should have a high therapeutic index. However, some important therapeutic agents have low indices. For example, although the therapeutic index of the cardiac glycosides is only about 2 for the treatment and control of cardiac failure, these drugs are important for many cases of cardiac failure. Therefore, in spite of a low margin of safety, they are often used for this condition. The identification of a low margin of safety, however, dictates particular caution in its use. The appropriate dose for each individual must be determined separately. It has been suggested that a more realistic estimate of drug safety would include a comparison of the lowest dose that produces toxicity, example LD, and the highest dose that produces a maximal therapeutic response, example EDGG. A ratio less than unity would indicate that a dose effective in 99% of the population will be lethal in more than 1% of the individuals taking that dose. Figure 2 indicates that phenobarbital's ratio LDS/EDGG is approximately 2. Protective index. The margin of safety is only one of several criteria to be used in determining a drug's clinical merit. Clearly, The therapeutic index is a very rough measure of safety and generally represents only the starting point in determining whether a drug is safe enough for human use. Usually, undesirable side effects occur in doses lower than the lethal doses. For example, phenobarbital induces drowsiness and an associated temporary neurological impairment. Since anticonvulsant drugs are intended to allow people with epilepsy to live normal. Since an entire dose-response relationship is determined from one animal, the curve cannot tell us about the degree of biological variation inherent in a population of such animals. Rather, variability is reflected by a family of dose-response curves, such as those given in Figure 2.3. The ED in this type of dose-response curve is the dose that produced 50% of the maximum response in one animal. In guinea pig E, the maximum response is an increase in heart rate of 80 beats per minute. Thus, 50% of the maximum is 40 beats per minute. From Figure 2.3, it can be seen that the dose causing this effect in guinea pig E is about 3 Yg/kg. The average sensitivity of all of the animals to levodorenol can be estimated by combining the separate dose-response curves into a mean, average, dose-response curve and then calculating the mean ED. An estimate of the variation within the population can be indicated by calculating a statistical parameter, such as a confidence interval. It is also possible to construct quantal dose-response curves for drugs that produce graded responses. To do so, one chooses a quantum of effect, for example, an increase in heart rate of 20 to 30 beats per minute above the control, or resting, rate. Doses of the drug are then plotted against the frequency with which each dose produces this amount of effect. The resulting graph has the same characteristics as the graph for the anticonvulsant activity of phenobarbital. The doses in figures 2.2 and 2.3 are on not an arithmetic but a logarithmic, or geometric, scale, i.e., the doses are displayed as multiples. This is more apparent in figure 2.3 because of the greater range of doses. There are many reasons for the common practice of using geometric scales, some of which will become apparent later in this book. One important reason is that in most instances significant increases in response generally occur only when doses are increased in multiples. For example, in figure 2.3, curve E, if one increased the dose from 10 to 11 or 12 Kg/kg, the change in response would hardly be measurable. However, if one increased it 3 times or 10 times, i.e., to 30 or 100 Yg/kg, one could easily discern increased responses. The concept of therapeutic index as a measure of the margin of safety has already been discussed. In the ratio LD/ED, the ED can be obtained from either quantal, Fig 2.2a, or graded, Fig 2.3, dose-response curves. In the latter case, it must be a mean ED, that is, the average ED obtained from several individuals. Potency and intrinsic activity. Another drug characteristic that can be compared by use of ED values is potent Y. Figure 4 illustrates the mean dose-response curves of 3 hypothetical drugs that increase heart rate. Drugs A and B produce the same maximum response, an increase in heart rate of 80 beats per minute. However, the fact that the dose-response curve for drug A lies to the left of the curve for drug B indicates that drug A is more potent, that is, less of drug A is needed to produce a given response. The difference in potency is quantified by the ratio ED/B/ED, 3/0.3 equals 10. Thus, drug A is 10 times as potent as drug B. In contrast, drug C has less maximum effect than either drug A or drug B. Drug C is said to have a lower intrinsic activity than the other two. Drugs A and B are full agonists with an intrinsic activity of 1, drug C is called a partial agonist and has an intrinsic activity of 0.5 because its maximum effect is half the maximum effect of A or B. The potency of drug C, however, is the same as that of drug B, because both drugs have the same edge, 3 Kg/kg. The ED is the dose producing a response that is 1/2 of the maximal response to that same drug. It is important not to equate greater potency of a drug with therapeutic superiority, since one might simply increase the dose of a less potent drug and thereby obtain an identical therapeutic response. Such factors as the severity and frequency of undesirable effects associated with each drug and their cost to the patient are more relevant factors in the choice between two similar drugs. Equations derived from drug-receptor interactions. It is important not to confuse the term potency with affinity or the term intrinsic activity with efficacy. The constants that relate an agonist A and its receptor R to the response may be represented as follows: A and R K, K, AR response affinity is KK and efficacy is represented by K. Thus, affinity and efficacy represent kinetic constants that relate the drug, the receptor, and the response at the molecular level. Affinity is the measure of the net molecular attraction between a drug, or neurotransmitter or hormone, and its receptor. Efficacy is a measure of the efficiency of the drug-receptor complex in initiating the signal transduction process. In contrast, potency and intrinsic activity are simple measurements, respectively, of the relative positions of dose-response curves on their horizontal axes and of their relative maxima. Affinity is one of the determinants of potency. Efficacy contributes both to potency and to the maximum effect of the agonist. Figure 4 shows that drug C has less efficacy, and less intrinsic activity, than either drug A or drug B. However, in contrast to intrinsic activity, no numerical value of efficacy can be calculated from the data presented. Unfortunately, the terms potency and efficacy are frequently used in a loose and misleading manner. The mathematical relationship of response to efficacy and affinity is the following: EA/M equals F multiplied by E, A, slash, Ka, A. This equation states that the ratio of the response, e.g., to a given concentration of an agonist to the maximum response, e.g., of the test system, such as an isolated strip of muscle, is a function, f, of efficacy, E, times the concentration of the agonist, A, divided by the dissociation constant, Ka, plus the concentration of the agonist. Chi is the reciprocal of the affinity constant and, under equilibrium conditions, A equals KRA/RA. R is the concentration of free receptors and RA is the concentration of receptors bound to agonist. Although the details are beyond the scope of this textbook, it should be noted that by the use of combinations of agonists and antagonists, dose-response curves, and mathematical relationships, it is possible to estimate the dissociation constants of agonists and antagonists for a given receptor and to estimate the relative efficacy of two agonists acting on the same receptor. Drug antagonism. The terms agonist and antagonist have already been introduced. The several types of antagonism can be classified as follows: 1. Chemical antagonism. 2. Functional antagonism. 3. Competitive antagonism. A. Equilibrium competitive. B. Non-equilibrium competitive. Non-competitive antagonism. Chemical antagonism. Chemical antagonism involves a direct chemical interaction between the agonist and antagonist in such a way as to render the agonist pharmacologically inactive. A good example is the use of chelating agents to assist in the biological inactivation and removal from the body of toxic metals. Chelation involves a particular type of two-pronged attachment of the antagonist to a metal, the agonist. One chemical chelator, dimercaprol, is used in the treatment of toxicity from mercury, arsenic, and gold. After complexing with the dimercaprol, mercury is biologically inactive and the complex is excreted in the urine. Functional antagonism. Functional antagonism is a term used to represent the interaction of two agonists that act independently of each other but happen to cause opposite effects. Thus, indirectly, each tends to cancel out or reduce the effect of the other. A classic example is acetylcholine and epinephrine. These agonists have opposite effects on several body functions. Acetylcholine slows the heart, and epinephrine accelerates it. Acetylcholine stimulates intestinal movement, and epinephrine inhibits it. Acetylcholine constricts the pupil, and epinephrine dilates it, and so on. Competitive antagonism. Competitive antagonism is the most frequently encountered type of drug antagonism in clinical practice. The antagonist combines with the same site on the receptor as does the agonist, but unlike the agonist, does not induce a response, that is, the antagonist has little or no efficacy. The antagonist competes with the agonist for its binding site on the receptor. Competitive antagonists can fall into either of two subtypes, depending on the type of bond formed between the antagonist and the receptor. If the bond is a loose one, the antagonism is called equilibrium competitive or reversibly competitive. If the bond is covalent, however, the combination of the antagonist with the receptor is not readily reversible, and the antagonism is termed non-equilibrium competitive or irreversibly competitive. If the antagonism is of the equilibrium type, the antagonism increases as the concentration of the antagonist increases. Conversely, the antagonism can be overcome, surmounted, if the concentration of the agonist in the biophase, the region of the receptors, is increased. This relationship can best be appreciated by examining dose-response curves, as in Figure 5. Curve A is obtained in the absence of the antagonist. Curve B is obtained in the presence of a modest amount of the antagonist. The curves are parallel, and the maximum effects are equal. The antagonist has shifted the dose-response curve of the agonist to the right. Any level of response is still possible, but greater amounts of the agonist are required. If the amount of the antagonist is increased, the dose-response curve is shifted farther to the right, curve CL, still with no decrease in the maximum effect of the agonist. However, the amount of agonist required to achieve maximum response is greater with each increase in the amount of antagonist. Examples of equilibrium competitive antagonists are atropine, tubocurarine, phentolamine, and naloxone. Of course, this continual shift of the curve to the right with no change in maximum as the dose of antagonist is increased assumes that very large amounts of the agonist can be achieved in the biophase. This is generally true when the agonist is a drug being added from outside the biological system. However, if the agonist is a naturally occurring substance released from within the biological system, example a neurotransmitter, the supply of the agonist may be quite limited. In that case, increasing the amount of antagonist ultimately abolishes all response. The effect of a non-equilibrium antagonist on the dose-response curve of an agonist is quite different from the effect of an equilibrium antagonist, as illustrated in Figure 6. As the dose of non-equilibrium antagonist is increased, the slope of the agonist curve and the maximum response achieved are progressively depressed. When the amount of antagonist is adequate, curve D, no amount of agonist can produce any response. The haloacylamines, such as phenoxybenzamine, which form covalent bonds with receptors, are examples of non-equilibrium competitive antagonists. Non-commutative antagonism. Non-commutative antagonism, the antagonist acts at a site beyond the receptor for the agonist. The difference between a competitive and a non-competitive antagonist can be appreciated from the following scheme, in which two agonists, A and B, interact with totally different receptor systems, R and R, to initiate a chain of events leading to contraction of a vascular smooth muscle cell. X is a competitive antagonist, and Y is a non-competitive antagonist. X equals A plus R, Y equals B plus R. Depolarization, increased free calcium, R contraction. Antagonist X, competitive, has an affinity for R, but not Ra, thus, it specifically antagonizes agonist B. It does not antagonize agonist A. Antagonist Y acts on a receptor associated with the cellular translocation of calcium and inhibits the increase in intracellular free calcium. It will therefore antagonize the effects of both A and B, since they both ultimately depend on calcium movement to cause contraction. The effect of a non-competitive antagonist on the dose-response curve for an agonist would be the same as the effect of a non-equilibrium competitive antagonist, Fig. 6. The practical difference between a non-competitive antagonist and a non-equilibrium competitive antagonist is specificity. The non-competitive antagonist antagonizes agonists acting through more than one receptor system. The non-equilibrium competitive antagonist antagonizes only agonists acting through one receptor system. The antihypertensive drug diazoxide is one of the few examples of therapeutically useful non-competitive antagonists.